Everyone. My name is Julia Saracen, and I'm an injury prevention specialist with the Family and Child Health Division at the Vermont Department of Health. And I'm here with my colleagues from the University of Vermont Medical Center and the University of Vermont Larkner College Medicine, pediatricians, Dr. Breena Holmes and Dr. Becca Bell. We're going to start our time today with a 30-minute Q&A session, followed by a structured content presentation. We received some great questions, as Beth said, on COVID-19, pertussis, hand, foot, and mouth disease, head lice, and triple E. Our structured content section will start at 1:30 and focus on RSV. As we answer the pre-submitted questions, please feel free to ask live chat questions either by raising your hand or by using the chat, and to share any follow-up questions or ideas as we continue our conversation. Before I start, I'd like to encourage people to watch the recording of our July webinar on VTAUIC's YouTube, as we dedicated time during that webinar to focus on insect repellent application, hand, foot, and mouth disease, and VDH's COVID respiratory viral disease guidance. Do you want to start with answering some of those pre-submitted questions? So in response to several different questions, I'm going to share the expertise of our epidemiology and COVID-19 coordinator at the health department, John Davey. And it's important to share that as we move into the 2024 respiratory season, the health department is continuing to focus on now endemic COVID-19 in a similar manner to how we think of other respiratory viral diseases, such as the flu, RSV, and other cold viruses. So we got a couple different questions that we separated into their own categories. So the first set of questions is, please give very specific, up-to-date COVID guidelines for children. What are we doing about COVID exclusions these days? Is it exclude for 5 days, then return to school if they have a fever less than 100.4? What about coughs? What about runny noses? So there's no longer any COVID-specific guidelines, and we encourage facilities to use the same criteria for COVID that they would with other similar respiratory diseases. A child who has been fever-free without use of medication for 24 hours and sees improved symptoms can generally return to childcare. That being said, facilities are able to make their own policies and should feel free to reach out to local providers or their local health office to discuss this. There is currently no public health need for COVID-specific guidelines that are distinct from other common respiratory viruses. We strongly encourage vaccination for all who are eligible and remind facilities that masks and improved ventilation are effective strategies to reduce the spread of infectious respiratory viruses. The second set of questions is, what do you recommend in terms of home days and return to school for young children who test positive for COVID but are too young to mask effectively? Each facility can and should have its own policies in place, but we do not recommend any extended COVID-specific guidelines for children who may be too young to mask. Other strategies include distancing and ventilation, or having teachers, staff, or older children wear masks if there is a particular concern for their exposure due to being immunocompromised or having other risk factors. And the last set of COVID-related questions is, what are the current recommendations for COVID? What if someone who had a COVID exposure or recently had COVID and is returning to childcare? This is about children 0 to 5 specifically. Do they need to test to stay? No symptoms, no testing. So we do not have any general recommendations to test based solely on COVID exposure when there are no symptoms. COVID-19 testing should not be required to send someone home or for them to attend, and specific situations of concern can be discussed with your local health office. With that being said, I'm going to put the following information in the chat on resources that the health department has and ways to contact your local office of health. Does anyone have any more COVID-related questions?
Hey, Julia, can I editorialize a little bit?
Of course.
Hi, everyone. It's Breena. First of all, every time I come on this call and I see your names, I just feel like this weird mix of like pandemic anxiety, but also like this warmth and just gratitude for who you all continue to be for Vermont's children. So great to see so many of you on. I think we talked about this last time, but I'm really interested in reinforcing something here, which is that You all just went through something extremely difficult in the space of managing COVID when it was new and when we were all activated by policies, procedures, testing, return, symptoms, and we have hundreds of PowerPoints to document all the time we spent together in that space. So I don't at all, it wasn't surprising at all to me that your questions remain, because to get to march your brain across that chasm of all the stuff and the fears around that particular virus to this sort of steady state normal space now that it is a virus that affects our citizens just like all these other viruses is a big swing for some people. So I appreciate Julia just sharing the very official and important recognition that nothing special here, nothing to see here. But it's also gets us into this much bigger conversation that you've helped us with enormously, which is pre-COVID. We had a lot of sick kids with a lot of symptoms floating in and out of your care for those societal reasons that we're all really worried about, which is parents have no choices and it all falls to you. Just take the kid back. He's just a little snotty. And I want to continue to wonder about this ecosystem of you, parents, and the pediatric healthcare professionals that you work with, because I'm still hearing stories that some pediatricians are saying the kid's totally fine to go back. The parent brings that message to you, and you're stuck with yeah, great. He arrives 20 minutes later, he's lying on his mat and he can't even lift his head up for 6 hours. So I don't have a solution for you here, but a policy is not going to solve that. What's going to solve it is creating teams and what I call team-based care, and actually really trying to share uh, some space with your healthcare professionals. And I see a lot of the family and child health coordinators on this call. That's that district office, health department nurse who really can dig in with you on that. So if you're having a particular experience that pits like the healthcare team against what you're trying to set up for the health of your settings, let's get those family and child health coordinators involved and really do this relationally. Because if we start to parse like how many days and how much snot and how much energy exhaustion and how well the kid's eating and stuff, we're going to get too into the subjective where it can't really be mitigated through a webinar like this. So that might be too early in the webinar, Julia, to air that all out. But you guys, I can feel that we're back there again. And it's just going to get a little worse as the respiratory season really hits hard in the weeks ahead. Okay. I do see some chat on that.
Thank you, Breena. I think we definitely needed that after the very stringent health department talk, kind of humanize it. Another question we had was update on the pertussis spread, how to identify pertussis, and what to do if it shows up in your classroom. So, how to identify pertussis. Pertussis, also known as whooping cough, is a vaccine-preventable disease. It begins with cold-like symptoms and may cause vomiting, loss of breath, or difficulty breathing and blueness. The whooping, high-pitched crowing sound occurs when inhaling after a period of coughing, but might not occur in very young children. Fever is usually absent or minimal, and symptoms are more severe in infants younger than 1. And what to do if pertussis shows up in your classroom. So you can report a pertussis case within 24 hours to the reportable disease case report form. The information can be found on the Infectious Disease Reporting and Data website at the Vermont Department of Health, and I will put those both in the chat. You should continue to monitor staff and children for respiratory signs and symptoms and recommend treatment if a cough develops within 21 days of exposure. The child with pertussis should be excluded from the group setting, and close contacts who are also coughing should be excluded. Children can return after taking their course of antibiotic treatments and are able to participate in class without compromising the ability of staff to care for other children. We also got some questions
Julia,
on
I might just underscore that pertussis is not super common. It's vaccine preventable, but we do see it. And so just just to underscore what Julie said, it's reportable. And so this would be something if you were affected, or like the health department would work with you. So all the recommendations that Julia said is not something that you would be doing on your own at all. So that would be, you know, that lab is positive, that lab test is positive, it's going to get reported, and you'll have help with that.
Yeah, so that would also be a great time to connect with your local health office, to connect with your local family and child health nurse coordinator, who can give you all of those resources and that support that you need. We also received 2 hand, foot, and mouth disease questions. Just to reiterate, we did share a presentation on this in more depth in July. That would be really helpful if anyone wanted to check out to get more information. But the 2 questions were, what should be done regarding cleaning after a child is diagnosed with hand, foot, and mouth disease? Do toys, commonly touched surfaces, etc., need to be washed or wiped down with disinfectant? What about bedding for children that appear to be fine? Should everything get laundered? And what do you recommend for return to school when children have Coxsackie virus? Can they have blisters? So children can return to childcare when the exclusion criteria is resolved, which means that the child is able to participate. They do not have a fever, they are not drooling, and they do not have open blisters, which means that the blisters should be gone or dried up, and that providers can determine that they can care for the child without compromising the ability to care for health and safety of other children in the group. Families should talk to a child's pediatrician if they are not sure when their child should return to childcare. And those beddings, laundered, it should be laundered. Stuff should be continually wiped down and cleansed if there is a child or an outbreak of hand, foot, and mouth disease in your childcare. And to encourage hand washing, encourage kids not to be touching loose blisters, or yes, I can't slow down and talk.
I was just thinking the same thing, Julia. We might want to provide the written answers as well to the team through Beth, just because I do think it might be helpful. What we're really pointing out here that I'm sure you're accessing, the health department's website is very, very good. So it's way better than it used to be for those that have been around a while. So the links and everything that Julia's providing can give you that sort of below the iceberg thing you need, because you really do have to retain a lot of information in the care of children. And I will just say, while I'm unmuted, but then I'm muted and I'm back unmuted. Hand, foot, mouth, this is a tough one. There's like that official answer about the blisters, and then there's this drool thing. And long after, you know, kids have started with their healing for this virus, their mouth is still a bit on the sensitive side, as you know, which leads to just the drool and the drool. So I imagine you find yourself wondering if a child's still contagious, infectious with that drool, and the answer is sort of, which isn't very helpful in your settings. But again, if you can use your, you know, education of children principles, which is, you know, how is the child functioning? Are they able to attend to the fun day and to the learning? And if not, the exclusion becomes more in that arena once you've gotten past these check marks of the official virus description. So it's a long one. Hand, foot, mouth it's like a 10-dayer start to finish. And I know that most kids don't stay out remotely close to 10, nor should they. So again, I'm just trying to get in your space a little on how your world shows up this way and your staffing and what this looks like as a secondary or a primary factor to these conversations, as well as what information do you need to communicate effectively with parents, which is your day job, you know, what you do all day, every day.
Before we get into the triple E questions, I do just want to reiterate that we are all a resource, and I am a resource for all of you. And if you feel like any of these segments have been too short or you have different questions, please reach out to me via email, or we can set up a time to talk. Can answer any of these like health department questions any of these licensing questions in a lot more detail and take time to address your specific needs. So just as a reminder, that's something that you have as a resource. So to provide some background on Triple E, mosquito season begins in Vermont in the spring, but does not typically pose a health risk until summer months. The risk is lower when temperatures are below 60 degrees and mosquitoes become less active as it gets colder. Mosquito bites continue to be a risk until the first hard frost. So you might have heard that a lot in the health department, first hard frost, first hard frost. But a first hard frost is when temperatures dip below 28 degrees and stay that way for many hours. And that is weather dependent. So we don't know exactly when that's going to happen. It could be November, maybe late October. It really just depends on the weather. So child cares can lower the risk of Triple E by using smart pest control methods to prevent mosquito bites. This includes taking care of child care grounds to remove places where mosquitoes live, specifically standing water. It is important to dispose of or regularly empty anything that holds water or puddles. You should plan outdoor activities when mosquitoes are less active, so before 6 p.m. and after 6 a.m., and encourage children, parents, and staff to wear protective clothing such as long-sleeved shirts and pants, and to use EPA-registered insect repellent from dusk to dawn. And in July, we did have a longer segment on insect repellent use in regards to ticks, but this is also relevant for mosquitoes. You should also fix any holes in screens and make sure they are tightly attached to doors and windows, and avoid areas where mosquitoes tend to concentrate, such as tall grass and wooded areas. For programs in risk zones, you should follow the local official guidance from your towns and counties on holding outdoor events. There was also a specific question on advice for taking action if a child develops symptoms related to Triple E that are also similar to common cold, COVID, flu. Should parents be seeking medical attention for fever and chills? While symptoms of Triple E can look like symptoms of the flu, COVID, RSV, and other illnesses, families should talk to their pediatricians if their child is experiencing severe or concerning symptoms, regardless if the symptoms are believed to be related to Triple E or not. As a review, symptoms of Triple E may include fever, chills, body aches, joint pain, headache, vomiting, diarrhea, seizures, behavioral changes, drowsiness, or coma. I will also include our Triple E links in the chat for all of our health department information, as well as some more general guidance on what smart pest control looks like.
I'm sure you guys are interested in how we share acronyms and abbreviations across things that have nothing to do with each other. So in your world and a lot of my world, Triple E is early essential education, right? Part B. Yeah, the first time. So in healthcare, IPV is the inactivated polio vaccine, which was a pretty important part of my healthcare career. When I got to public health, everyone was talking all about IPV in a meeting, and I was like, I don't understand. And it stood for intimate partner violence. So just a reminder to talk, jargon bust if there's something we're saying that because Triple E is uh
Eastern equine.
equine encephalitis. Yeah. The media does the same thing. I'm sure you have to check on that stuff the way I do all the time. What are we talking about?
So we did get a question, should children be wearing DEET on clothes, only your skin? Also, families are asking this. So DEET is a safe and effective tick repellent. It can be used on skin not covered by clothing. For children, use products with the lowest amount of DEET, so up to 30%. DEET is approved for children older than 2 months old. For children younger than 2 years old, their skin may be delicate and thinner than the skin of an older child or adult. Because of this, it is important to use DEET sparingly when needed. So there have been recommendations on putting netting on playpens or baby bassinets if you're bringing a child younger than 2 months old outside, or limiting outdoor time during that dusk to dawn, and never use repellents containing oil of lemon eucalyptus with children younger than 3 years old. Avoid using sprays in pressurized containers as that may get into children's eyes, and avoid using repellent on children's hands as they may also get that into their eyes and into their mouths. Insect repellent, 2 months old. So for children younger than 2 years old, but DEET is approved for children older than 2 months old. And then insect repellent use it directly onto a child's face instead of spraying it. So you can spray a little on your hands and then rub it onto a child's face, making sure to avoid their eyes and their mouths, and don't use insect repellent on cuts, wounds, or irritated skin. And just to clarify, I meant DEET for children older than 2 months, but being careful to use it sparingly with children younger than 2 years.
Awesome, Julia. And Becca put the healthychildren.org inside. It's really, I reference this constantly. I really would encourage you to go on healthychildren.org. I've had to use it recently for 5 or 6 different things, and it's a very well kept up-to-date resource by the American Academy of Pediatrics, and it's short and answers my question in 3 minutes. So hopefully that's a good resource for you as well. It's hard to keep up with all these threats to health. I think you're muted, Julia.
Oh no. Okay, so now I have some questions that Breena and Becca are going to answer. The first is COVID, flu, triple E. What thing should we really be worried about?
Wow, Becca?
Yeah, I think it sounds like the question is saying, you're working, you have a child who's sick, like, what are you worried about? How do you we talk about in medicine, we generate this differential diagnosis and, what's going on, what's causing this. So you don't need to figure that out. That's actually not something at all that you need to sort out, whether it's COVID or flu or anything else, because what you would do is what you would always do, which is if the child's not able to participate in the day, then they need to go home. I think the question around whether then you recommend, usually it's a shared decision making, right, between like the parent, the caregiver, and you all. And I think just relaying the information to the parent or caregiver, like if you're like he's been like a lump on a log, like laying on the floor, not doing, just relaying he didn't drink anything, he didn't eat anything, he threw up, whatever. Just relaying the symptoms to the caregiver is important so that they can sort of decide next steps. And I think, just we're talking about triple E, which can cause an encephalitis meningitis. There are this isn't to confuse you, but just to say that like there are other viruses that cause those things. So I just had a case of an enterovirus meningitis, which is a virus that's not spread by mosquitoes. It's a very common virus. And so like whether it's, mosquito, et cetera, like that cause it, if a child's really unwell, we're not asking you to do anything different than you would ever do beforehand. And your job is definitely not to try to figure out like, what virus or what bacteria or anything else is causing it.
Yeah, and this is a good time for me to remind or to offer, if your children in your care don't have access to medical care, or there are barriers to them actually seeking medical attention for things like the symptoms we've described today, then again, these family and child health coordinators in your districts can help you with that, as can Becca and Breena, through Julia or Beth. That I'm aware that we have very good health access in Vermont, but that doesn't always mean that each individual child has what we call a medical home, like a place they can really reliably get in. We're pretty proud about pediatrics in Vermont that we don't say we'll see you 2 weeks from next Friday, the way adult care seems to be showing up. We really try to see kids when they're not well on the day that they're not well. So I hope that's your experience, but if it isn't, let me know. And way further back in the chat, I wanted folks in the Chittenden area to note that Krista, who's our new family and child health coordinator in Burlington, was so generous that she just went ahead and put her email right into the chat for you Chittenden County folks. So take her up on that before she gets too busy and tired to, no, I'm just kidding. Take her up on that offer to really check in, because I can feel you really want this medical anxiety, there's a lot to worry about. And that whole idea that how to prevent a mosquito from landing on a child, it's just too much for you. I can feel it. The only thing I'm grateful for in that space is that most of you aren't providing care at twilight, right? Because that's the highest risk time and I don't think I've ever really wished for frost, but you can certainly breathe easier after that. But we can keep it warm for a little longer if that in that space. So I want you to feel like you have shared decision making and a team of people wondering about stuff together, so you're not on your own.
I just want to be mindful of time for Becca. Do you want to keep answering questions, or do you feel like you need the full 30 minutes for the RSV?
I need 15 minutes and then some time for us to all chat about reflection. So like
I
20,
think that
that's fine. Yeah, we can answer some more questions, I think.
okay. We'll try to get through as much as possible, but if you did submit a question and we don't get to it, we will send out the answers to all the questions with Beth. So they will be answered, and feel free to keep putting stuff in the chat as needed. We'll make sure those get answered as well. So we have another question. I was just curious about the best steps. We cannot administer Benadryl in preschool ever, correct? A child recently got stung by a bee, and when I checked in with mom, she said they have a family history of bad reactions. She said that the child has never been stung, so they were unsure how they react. If they started to have a reaction, would we just call 911 for immediate help because we cannot administer Benadryl? Or can you ever call and get verbal permission over the phone for emergency situations?
Yeah, I'll take that one, and then Becca can embellish that. Uh, can't give Benadryl in that age group ever. And if a child is starting to react to a bee sting, that's a medical emergency and you need to call 911. And I think any sort of attempt to mitigate that, even with Benadryl, if the child was old enough, makes me very nervous. So to me, it's the perfect use of emergency medical services because anaphylaxis is fast. And some of you are pretty rural, and I just want to leave that as a note. Those are some of the cases that really stay with you in community pediatrics. And allergy is a bit mysterious. But that being said, I'll answer the other question while I'm unmuted, that folks are wondering about this peanut-free environment. And Becca and I talked about it before. We don't have the space to tell you. We don't know because we haven't updated ourselves on childcare regulations in that space. But the current field of allergy and immunology and pediatrics does not do no peanut rooms anymore. So you might be stuck between like old policy and new, and we need to get back to you so that we don't misspeak in the world. The nexus between like common sense pediatric advice and what you're actually held to in your regulations. So can we hold that one, Beth and Julia, and just make sure we don't tread? The concept is that if you know someone's allergic to peanuts, you just keep them away from people eating peanuts. You don't have to ban the whole classroom. And so this area has been a bit of a pendulum in the world of early care and education, as well as school, older kids. But our current best thinking is it's pretty over the top to do the full ban. Becca, did I say that right? Yeah. But I'm hesitating because I'm just a little concerned that it's still in childcare regs or something, and we'll get back to you.
We can get a more official answer out when we send.
Great.
Okay. Why isn't lice or nits a send home thing?
Oh my God. And this one's mine as well. Okay, head lice is it's like a flea or a little rash, a scabies. It's not about hygiene or poverty or all the stuff that got completely overstated back in the 80s that caused so much stigma and so much inequity in care that we finally got it right in the 90s and said stop with the exclusion in the middle of the day and creating all of this stigma that these two kids have to go home because they have, so a couple of little nits, and we really need to stay. And I know you guys live in this space too, that we have to calm ourselves down in the emotional regulation and the parents that treat it like it's anything more than just a common little occurrence that happens to almost everyone. So that's why we don't run around and exclude. Now, you can certainly advise parents on treatment, and we can give you resources on that, and you can, uh, want the treatment to have occurred before people come back. But it's that 10 o'clock in the morning seeing the lice and thinking now I have to shut down the whole thing and get this kid out of here that really led to a lot of stigma. Yes.
Question in the chat.
Yes, Molly. Yes. So we can get you the official, there's like 4 steps. And then the treatment of head lice is also a bit, there's a lot more evidence now, but there's like 4 layers to it, and you can start at any layer you want. Some people go straight to like prescription, others are fine over the counter. When I had it at my house, which was when my kids were young, quite a problem. We used a lot of olive oil and mayonnaise, like there's home remedies. I know that sounds crazy coming from me, but I couldn't, it really did work to smother with olive oil. So I'll get you guys the right resource for that because there's tons written about this for protocol, but I did want to address I know we all don't like it, and when we see it, we have a reaction, but we have to be careful about that because it is so stigmatizing still, and there's no reason for it to be.
Can I go back to the bug bite, the bee sting thing just really quickly? Because I think there's 2 different things that people think about. One is there's a local reaction to a sting, or even like mosquito bites. You've probably seen some kids or experienced yourself with a sting. Some people get stung and like you can barely see the little dot afterwards, and some people develop these like areas where it's like very red, sort of swollen. It can be really itchy and uncomfortable and feel warm. So that's a local reaction. That is a totally separate pathway and a very different thing than what's called a systemic reaction or anaphylaxis. And so it sounds like actually from that question that parent may have been actually maybe referring to more of a local reaction type thing. So again, if you've got a child who's got this local reaction, that has nothing to do with anaphylaxis. So you're not like, oh my gosh, where they got stung is really red, they could go into anaphylaxis. It can be kind of uncomfortable. And so like the stuff that you normally do, like icing it, that actually works better than something like Benadryl anyway. And then separately, just to be really clear about anaphylaxis, what that looks like is that it can look like a few different things. It can be like a full body rash. It could be difficulty breathing. It could be just vomiting, even just vomiting after a sting. And you all are, kids are going to get stung for the first time. Like they're going to have unknown, like their allergy history is going to be unknown. And that's where we tell parents this all the time. Don't screw around with like giving some Benadryl at home and seeing how it does. That is, if you've got, one or two, even just 1 or 2 of those symptoms, that's a 911 call, and, epinephrine is life-saving in that case. So I just want to separate the like local reaction piece to the like systemic anaphylaxis, 2 different things.
Yeah, that's a great point. Okay, a couple things. I put the reference for head lice in. There is, you can use hot water to wash the materials, or you can leave them in a bag for 2 weeks. I don't know who would ever do that. And I just did a quick lit search on the olive oil thing because I can't believe I shared that with you, and there is no evidence olive oil works. So I want to strike that from the record. There's no harm. I want to be clear on that, but it isn't in the current 2024 evidence base, so let's not promote that any further.
Okay, Becca, I think we're good to start our RSV 101.
Amazing. Okay, I have some slides, and here's what's good about me waiting until the last second, i.e. today, to get these slides in, which is they're extremely up to date. So I'm actually going to talk to you about, and hopefully I'm just going to keep talking because I think you can see the right slides. This is a story about hope, and it's actually an action request from you all. I think this is a real opportunity for us to partner, for pediatricians and the health department to partner with you all, because what we're going to talk about, RSV, is something that really uniquely impacts the population that you work with. And I feel like you are uniquely positioned to help this effort to reduce severe RSV infection. So I've talked about RSV with you all in the past, and I'm going to just kind of briefly go through this to talk about the new prevention that we have, because it's very exciting. But I'm happy once I kind of go through this to go back to some of the basics. And Julia, I can't see the chat because my slides are up, so you can just interrupt me if people have questions. Okay, so RSV stands. Oh, go ahead.
Do other people see Becca's slides? No? Okay.
Oh, okay. All right. Thank you. Let me try this again. Thanks for speaking up. Let's see.
Okay, that looks good. And I will just drop in if any questions pop up.
Perfect. Okay. Thanks for saying something. Okay, so hopefully that's good, right?
Yep, it's great.
Okay. Great. Okay, so respiratory syncytial virus, super common. We all get it. We get it over and over again every, maybe not every year, but we get it all the time. We get it as adults. Everyone is basically infected by the time they're 2 years of age, but that first infection is usually the more severe infection. And it is the most common reason for children to be hospitalized in the United States. 60 to 80,000 children every year under 5 are hospitalized. That being said, basically every child almost is getting RSV. So that's still a pretty small, the denominator here is huge. So all these children are getting RSV. So about 2 to 3% of children under the age of 1 who get RSV end up in the hospital. But what that translates to is a lot of hospitalizations because a lot of kids are getting RSV. There's no specific treatment for RSV once you're infected. It's what we call supportive care. And so there are things that we talk about with parents about home care and like suctioning and make sure they're well hydrated. And then we have reasons to come to see your pediatricians. We have reasons to have to come into the hospital and reasons to come to the ICU. Most of that has to do with like either dehydration or inability to breathe, like working hard to breathe, not getting enough oxygen in, that sort of thing. But there's no benefit to say getting tested early and starting on a medication or something like that. This isn't a bacterial infection where you can get antibiotics and like slow down or reduce the course. So there isn't a specific treatment, which means we don't recommend people get tested. So this wouldn't be a story where, if you hear in a couple months, a family says, oh, my child was sick, I brought them to the pediatrician, and for a bunch of different reasons, they were trying to sort something out, and we did find out that they have RSV. That's not something that you need to tell folks about, or you need to recommend that people get tested for, because we know RSV comes around every year, and we know like basically everybody gets it every year. And so the management is really just like any other respiratory viral infection. Here's the thing though, why why do I care about this? So I work in the pediatric ICU. This is the biggest, most common reason why children get admitted to the pediatric ICU. So here, I just wanted to show you what the season tends to look like. This is national. On the bottom, you've got the months. So you start with October, which is usually when we first start to see RSV in the United States. We don't tend to see it in Vermont yet. So this is national data. That purple dotted line, if you can see, I don't know if you can see my, probably not. You probably can't see this, but the purple is, can you see my mouse?
Yes, we can.
Oh, perfect. Okay, so this purple right here is sort of pre-COVID. So 2019 to 2020, that's like a typical course. So really it tends to last about 12 weeks. Once it starts, we know it's just going to ramp up. It's going to go through the population, and it's going to be, for me and everybody who has small kids, like terrible for 12 weeks. My family knows when it's RSV season. They're like, oh, we never see mom, because I'm just like, it's so busy. After during COVID, we didn't really see much RSV, hardly at all. It was really, we had really low hospitalization rates in Vermont. And then once kind of we emerged from the pandemic, we did have RSV came back. It came back a little bit earlier than usual. So this is the green was 2 seasons ago, and then this was last season, the red. So when you look at this and you look at the months, just shift it over a month or two to the right for Vermont, because it tends to start in the south of the United States and move up north. So I put here, generally, like pre-COVID, our busiest months were January, February, and March. So we're having this discussion, like sort of as we're heading into, we might start to see some cases in December. That's typically how it goes, and then it really ramps up, super busy January, February, March. We might see some cases in April and May, just as like we head off to this other side of the curve here. Okay, so this is like, I'm going back to this. This is national data, and this is like all age groups, just to show you the seasonality of RSV. The question is, after COVID, as we're emerging from COVID, and we had a lot more RSV, we had more RSV than usual, just because so many kids hadn't gotten it yet, and so we didn't have a lot of hospital beds, and it was a little bit of a crisis. And you probably heard about RSV in the news. This was 2 years ago, but then you probably haven't heard about it again, or most people haven't heard about it again. But it's still a huge problem. It's a problem every single year, and the reason why we don't hear a lot about it, I think, is because it affects mostly very young children. And so again, I know that you probably heard that older adults also can get RSV and they can get sick, and that's certainly true. But like, I pulled out the ages for you. This is what I want people to understand. That purple line, these are hospitalization rates. These aren't just like who tests positive. This isn't like we swab your nose and you're positive. This is, you're sick enough to get admitted to the hospital. That purple line is a 0 to 4-year-old age group, 0 to 4. The next, this blue down here, is over 65. So this is us. This is like our patients. This is the population that you work with. If you pull out just 0 to 1-year-olds, it's like off the charts. You couldn't even get it on the chart. So this is really a real problem for infants and toddlers, really. So it's exactly your population. And as soon as there wasn't, a massive bed crisis, and it went back to the regular patterns, like we don't hear about it in the news anymore, but it definitely affects us, and it affects the families that we work with. So again, this is last season. This is hospitalization rates, and this purple is the 0 to 4-year age group. And then you want, when we compare it to other viruses, this is also last season. This green, this is 0 to 4-year-olds. This is, again, hospitalizations, not just people who test positive, but they're sick enough to need to be in the hospital. This green is RSV. The blue is flu, influenza, and the red is COVID. So, like what we see in the hospital in terms of the children's hospital, what we see in the ICU, it's RSV. As kids get older, flu becomes a little bit more of a prominent reason to get hospitalized. The flu shot's really important. And RSV comes way down as kids become like more into the school age or as adolescents. So this is like a very specific population that's affected by RSV. Okay, so what are the kids that are at higher risk for RSV hospitalization? So they get sick. Again, like I'm saying, everybody's getting it, but who gets really sick from it? So the younger you are, the more sick you can get. So especially those under 6 months of age. If you have, if you're caring for an infant that like had been in the NICU, like say they've been in the NICU for a month or two, now they're out, now they're in, with you, that kid, that child is at higher risk. Babies that were born premature, even if it's just a few weeks, if they're young and they were born a few weeks premature, and we can get into the details of why this is, they have an immature response to this virus, and they just can have a lot of trouble breathing. And so prematurity, even just like a 3 weeks, 4 weeks, 5 weeks early, leads to a higher risk for RSV hospitalizations. And here's the thing where I just really want your teamwork with, is that truly, every day during the season, I'm admitting multiple children to the ICU, and I walk in and it's like a 3-week-old, and I say, I'm sorry you're here. Let's, tell me about your family. Let me guess. Does your baby have an older sibling? And they say yes. And I say, is it a 2-year-old in childcare? And they say yes. But this is how all these babies who are like 10 days old, 2 weeks old, 3 weeks old, 4 weeks old get exposed to RSV. It's from always like the sibling, and usually the siblings in childcare. And so I do want us to think about the folks, we think about it, the folks in our practice, but the folks in your community that are expecting a baby. You might be caring for a 2 or 3-year-old, and they're expecting a baby, or a baby has just been born and is a couple months old at your center. So those are the infants really that get the sickest. And so the key with like mitigating this is to delay when they get their first RSV infection, or to somehow make it so that they are able to not get as severely sick. And what you really need to do is get kids like right when they're born and protect them really early. And here's the good news, is that we can do that now. And this is super exciting for us. So in particular for infants, we have, they're sort of calling it an immunization for RSV. It's called nirsevimab or Beyfortus. And what it is actually is it's not quite a vaccine. It's what we call a monoclonal antibody. So if you recall, when you get a vaccine, it prompts your immune system to make some antibodies, right? That takes a little while. Remember how we talked about getting the COVID vaccine, and then you're not really protected for like a week or so. But nirsevimab is like the antibodies are already made, they're already there. And so when the infant gets it, you've already got the antibodies there. So nirsevimab is approved, and not just approved, but recommended for every single child, even children born on time. They have no health problems, a healthy, 6-month-old. It is recommended that they get nirsevimab, and that you want to get it as the RSV season approaches. Infants born during RSV season should get nirsevimab. So if there's a baby born in December in Vermont, they'll be offered that nirsevimab hopefully before they leave the hospital. There's also a category for high-risk toddlers in their second season, which that's something that the pediatricians know about. And this is going to be available in pediatric offices in October. This was available last year, but it was in such short supply and such high demand that not everybody who wanted it was able to get it. And we didn't spend a lot of time talking about it because it was just so limited. But this year, we don't expect there to be any supply issues. This is a video going back. This is on Healthy Children too. I have the link there, which Beth can send out to this article about RSV, what it looks like, what to look for, and then this nice video about what nirsevimab is. And this is a CDC poster. This might be something to hang up in your center. I have the link here as well. But basically, there are 2 options to protect infants from RSV. One is, well, the number 2 that I have listed there is that the RSV antibody shot is given to the infant during their first RSV season. So basically, any babies that have been born this spring, this summer, this fall, this winter, they're all eligible to get this, and they should get this. The other thing that can happen is that we can give a vaccine, a maternal vaccine, to a pregnant person as they're nearing the end of their pregnancy. but with enough time that they get the vaccine, they build up antibodies, and then they pass those antibodies on to the infant. So when the infant's born, they've got those passive antibodies there. So that's another option. That maternal vaccine is already available. They've started to give it out in September. So those are sort of the two options there. The question is, how effective is it? So in clinical trials, so this is like as part of the approval process, nirsevimab, so this is the shot that we give to infants, was 80% effective in reduction of hospitalizations and 90% reduction in need for hospitalizations with oxygen. Sorry, I worded that a little bit weirdly. Basically, like just a 90% reduction in children needing oxygen who are hospitalized. And then we've got some data from the real world. I told you that not everybody, there wasn't great supply last year, but there was enough that they were able to study this in the real world during last year's season. And it kind of shows what the clinical trial shows, which is really exciting. So a 70% reduction in hospitalizations for those children who got nirsevimab and a 90% reduction in the need for oxygen. So when I say, you know, I used to always say, I will never lose my job because RSV keeps us so busy. I don't know. I mean, I wouldn't mind if I go out of business, you know, if I don't go out of business, but if they don't need us as much in the pediatric ICU, I mean, this really, really could make a difference if people get it. And again, the key is to get it right as RSV season is starting. If a baby's born during RSV season, to get it like right then, like that's the key. And the other important part is it doesn't really, it can reduce just infection completely, but really, again, just like the way we think about COVID vaccines, that the point here is to make it less severe in that first infection. It's not going to prevent RSV from spreading. People are still going to have RSV, but it's to give that extra layer of protection, give those antibodies to those infants so that when they are exposed to RSV, they are protected and they don't get so severely ill. So this is my last slide. I really find this super hopeful. So the maternal vaccine is available now. Nirsevimab will be available after October 1st. And I would love to open it up to talk about how we can collaborate a little bit on how to get the word out. And, you know, just even simple things like I'd love to hear in the chat, like how do you communicate with families? Is it through an app? Is it through email? What's the best way? Is it posters to hand out? Is it links to websites? Is it like little short TikTok videos? We can do all of that. Like, how do your families like to consume their information? Because we'd love to think about how to get this up and running so that we can start protecting, especially our youngest children heading into this season. And I'm going to stop there. Okay, so Becky is saying that they use an app, but you can post videos and photos into the app. Okay, so you know what we can do: emails, posters, links. Okay, so would it be helpful, even because I know some places will do like a weekly email update in addition to app communication? Whatever we can do, we can write like a super simple. I think like shorter is better. So just like great news, there, you know, we're able to protect infants from severe RSV, and then even just really basic things like nirsevimab's available now starting after October. Please talk to your child's physician. Here's a link to the health department. Here's a link to CDC. Something like that. Yeah. So the question is, what's the age? So it's really it's basically anyone under 8 months. And so as you head into like infants in October, so basically the idea is to protect people during their first RSV season. So we had RSV kind of through February, March of last year. And if you think about the timing, like, so if a baby was born in March, they may not have gotten RSV yet, so they should get it this season, right? Because they're like still less than 8 months of age when October starts. So the idea is to protect them during their first season. That's where they came up with the 8 months.
Do folks have newsletters? Good old fashioned. That'd be another good place. And Becca's not offering this, so I'm going to offer. Becca could do a short little video for you, TikTok or
Yeah.
otherwise. She's very good in the media, as you can tell. Oh, Becky wants
Okay.
a TikTok.
Yeah. Okay.
Woo!
I have a few TikToks of like from a year ago or 2 years ago when we were in that surge, just about RSV in general. Like, what do you do? What do you look for? When do you see someone? But not about this. I haven't made any about nirsevimab yet because we didn't have enough last supply. So I can make a couple and then I can send you just like the basic RSV 101 stuff and some on specifically about nirsevimab. I think that's how people get a lot of their information. So
Yes.
yeah.
Tammy wants to follow you on TikTok, Beck. How do you do that, Dr. Becca?
I'll put it in. I think it's Peds ICU something.
Oh, Peds ICU. Yeah, I get to say this because she's my pal. She is really skilled on that platform. Lots of topics. Wow. And funny too. You know, you can see we both like to sprinkle a little humor in because life is hard. Need to keep it, keep us figuring something that's funny.
I also have it on Instagram as well. I honestly haven't updated it since like 2 RSV seasons ago, but now I'm all motivated to do it again. So I'll start posting some stuff.
And I think we can end because it's 2 with Tammy. I really that's what they call in healthcare a doorknob question. You know, when you've done a whole visit with a family and then you get up to go and the parents says, I'm thinking about not vaccinate, that needs time. So if you want to talk about vaccine hesitancy and sort of the strength-based approach to those conversations, maybe we could get Beth and Julia to put that on for next time. I think you're a very trusted resource for families and you will come alongside them and wonder with them about that before just providing too much information. Because I guess we could end by, I was taught by this incredible pediatrician in my residency who drew the family in the middle of a circle and then asked new families, who's your community of people you're asking questions about your beautiful new baby? And that's when you learned that the pediatrician was one of them, but there was an awesome childcare provider, that their sister was a pediatric ICU doctor, their mother was a chiropractor, and you started to understand their influences. So that would be my doorknob advice, with the promise to talk more about it later. You might want to just wonder with the family where they're getting information about that decision, and then we would have more to try to understand. The curiosity space is the best to start. It's a very complex decision, as many of you probably know. Okay, 201. Sorry, Beth.
Thank you so much. Thank you, Julia, Dr. Holmes, Dr. Bell. We look forward to seeing folks in November, and we will follow up with an email with today's recording and all of the resources that were shared. Thanks.